Hi everyone. Um, a warm welcome from KIMS Hospital and good afternoon everyone. This is Dr. Nirmala from the Department of Urogynecolgy and Gynecology at KIMS Hospital, Secunderabad. It's a pleasure to speak on the topic of the uses of robot in the branch gynecology. As everybody is aware, robotics seems something very sophisticated and gynecology seems very simple. So putting them together, it's always a little bit of understanding that is needed. Sometimes there is a high created, few people think that perhaps robot has no role. So here are a few myths and misconceptions, and being practicing in this field using the robot in this field. So there are a few points that I would like to throw light on and bring this technology for a wider use. That is the precise concept. So next, please. To begin the presentation, I would like to thank my seniors, Dr. Neena Desai, who is the retired professor from this department, and she was the founder of the Department of Urogynecology and the first gynecologist, also a robotic surgeon in the city of Hyderabad. My mentor, Dr. Anuradha Koduri, who is the head of the Department of Urogynecology in KIMS. And anything I say about her would be actually less. So not to waste more time, Dr. Suresh Kumar sir, who is the surgeon and the chief of robotics in the hospital, and also the entire team of Intuitive Surgicals for their relentless efforts towards the development of this technology and its use in the medical sciences and services. Next, please. I'm trying to keep this presentation as simple as I can. As we all understand, the human being as a species. So we all know the theory of Charles Darwin that there has been an evolution over millions of years. So today, as we see the human being as we are today, we have quite a developed brain. Next, please. So we have been using this increased capacity of the brain, which over last 3 to 4 million years we see has more than doubled. So with this increased brain capacity, we are developing in all fields of life and we have all the comforts. So the same has to be applied to medical sciences as well. Following this concept, next please. So applying this advanced brain and the technology that we devise, the approach in modern medicine, what we practice today, as we all think of, consider the basic modalities of medicine like Ayurveda, homeopath, and allopathy. It is not allopathy anymore. It is described as modern medicine. Here, it is not modern as such to call it by the term. It has been there ever since the medical sciences have been evolving. So the approach is that we listen and we understand the history. History is basically how the patient presents with problems. So we understand the course of the problems, understand the kind of disease that might be there. We observe and try to understand the process. We do some investigations like blood tests, some ultrasound scans, etc. So to understand the disease in greater detail, and we manage either by close monitoring or by intervention. So the intervention is either medical in terms of medicines, and the other modality is surgical when, of course, the medicines are beyond help, or there is a combined surgical and medical approach. Next, please. So coming to the basic understanding of measurements of a few parameters in the body that we need to understand the basic problem, to reach to a diagnosis. So these are non-invasive tests which we are commonly using at our home in the clinics. So these are techniques or procedures that do not involve puncturing of the skin or entering inside a body at all by any way. So introduction of a foreign object like even a syringe. Okay, so that is an invasive procedure. But here we measure without harming the body at all, like measurement of BP, measurement of temperature, and even a therapeutic measure like radiotherapy. So these are also common examples of non-invasive measures or techniques. Next, please. So as we proceed, when we do not get enough information from this, we need to go with minimally invasive techniques. So all of us have heard of angioplasties, where we go inside the blood vessels with small catheters. Catheters are nothing but tubes, and through that, we achieve the necessary result. Similar, so the simplest of them is a syringe, a hypodermic injection. And as we take them higher, the coronary catheters, angioplasty, stereotactic surgery, where we localize the target and either take a biopsy or give some treatment, deliver some laser treatment or some other similar treatment there. Also, there are percutaneous surgeries like under the skin using a syringe again, and laparoscopy surgeries. They are also included into the same heading, and also all endoscopic procedures. Next, please. So when these are not enough for us, the next thing we traditionally know is open surgery. So incision that is a cut. It is made in a body part that allows us to have an access to the part which we need to treat. And here the tissues and structures are exposed to the air. Either we do it with our direct eye vision or using loops or microscopes. So this is the traditional open surgery. Next, please. So obviously we can see that there are so many disadvantages with the open procedures. Because everything is open, there are higher chances of infection, more blood loss. There is more handling of the tissues, which can later lead to adhesions and pain. There is more suture material is nothing but the stitches that we use. There is a risk of foreign body, like gauze pieces. People have heard of it, and more pain after the surgery, and also more time for recovery using the effective work time. Next, please. So we always are on the constant instinct of expansion and improvement over the technology. So here we started with minimal invasive surgeries. So how it started, first of all, it started in the early 19th century with a cystoscope. So cystoscope is nothing but a telescope to look inside the bladder. So the bladder, the urinary bladder, initially the light which we used was something similar to a candle light which was flickering. That's how the initial endoscopic procedures started. And the same instrument, the telescope, was applied to other parts of the body. However, there were further inventions and improvements, and that led to treatment of TB patients with thoracoscope. Later, in the 30s and 40s, we came to laparoscopy, which was used only for knowing the problem, that is diagnostic purpose. After that, we used the scope for evaluation of infertility, and further in 70s and 80s, we proceeded with further procedures. Next, please. So as we can see, there has been a constant improvement and development. This we could call a success, but is the success a cakewalk? No, never for anyone. So here there are just two examples I wanted to quote. That there was a survey in 1966 which documented that it was not a very safe procedure because many people were not equipped and capable of doing this procedure. So it had criticism, and after a brief start of endoscopies, most surgeons abandoned the procedures because of the limited therapeutic applications, because people did not venture doing it and land in problems, which is not completely wrong, but at the same time, as our approach is for constant improvement, we venture with improvement of technology. Next, please. So now this is the spectrum today. Like for every organ you mentioned, every orifice you can think of, there is a telescope which can go in to understand and study the organ in detail and perform respective procedures as per the need of the disease condition. Next, please. Next, please. So coming to laparoscopic surgery. Previous slide, please. Coming to laparoscopic surgery, lab is nothing but related to abdomen. So there is a keyhole that we create into the abdomen. So that is also called a keyhole surgery or a band-aid surgery, because that hole does not need to be stitched with too many stitches. It's just a band-aid that is required for it. So this technique, with the use of telescope that goes into the keyhole and the gas that is filled in the abdomen to make it into a balloon kind of structure. So the gas we use is carbon dioxide. It is put into the patient's body, and we operate through much smaller incisions that would otherwise be requiring a traditional big surgery. Next, please. So how are the laparoscopics, how are these two procedures different? On the left side, we can see there's a big open cut. And we are seeing the organs inside the abdomen, which is like definitely not appreciated by many people. And on the right side, we see that looks quite acceptable. So that is how different. And there is an obvious choice here. Next, please. So what is the outcome of these two surgeries? So the scar later can be seen in this space. So again, the choice is very clear. Nobody would opt for an open surgery if given a choice and if there is a feasibility to do it by minimal access surgery. That is laparoscopic surgery erstwhile. Now, as we proceed, next please. So are we satisfied here with this? No, we are always wanting more. The reason is because there are definitely few problems even with laparoscopy. There are certain limitations of laparoscopy, and this is maybe interpreted as incompetence on part of certain surgeons or not adequate training. But here I would like to confess very openly, and as all doctors would, as all surgeons would, there is always a learning curve for minimal access surgery. Learning curve means the more you practice, and here, of course, I should tell the practice is not on the patients, it is on simulators. So the simulators mimic the anatomy and the disease states as we find, and practice there makes us improve into our actual performance on the patients. So next, please. So to overcome the disadvantages, we are progressing into further technology. So the same application as we see with the development of telephones, we see this. What are we looking for? We aren't really captured in a cell, we are living in a cell, or we are living with the cell. Next, please. But we are looking for improvement in technology. Similar way, this was some 100 years ago, the car, and what we are looking for now is a self-drive vehicle. And we do feel comfortable at home with the present day technology, and that has become a need of the day, not just a luxury anymore. Next, please. Okay, so on similar lines, on the left side, we see a laparoscopy surgery where the surgeon is standing by the side of the patient, looking into the monitor, where the camera inside the patient's body is picking up the picture and displaying on the monitor, and looking at the monitor, we operate. That is the laparoscopy surgery. And on the right side, we see the surgeon in the red shirt is sitting elsewhere. The surgeon is not by the side of the patient. Instead, the robot is with the patient, and there is an assistant in the scrub next to at the patient side. So here, the development of technology, which we are going to look into details further. Next, please. So to tabulate, these are the major differences between the two surgeries. The incisions are tiny in both the cases. However, in robotic surgery, the camera is different, the instruments are different, and how the surgery is performed, the logistics are a little different, which we'll address each in the coming slides. Next, please. So coming to the incision, that is the cut in the abdomen. The first one we can see is one large cut, and this cut is not just on the skin, but we go cutting inside all the muscles and all the layers, and that, of course, as it sounds, it is painful. And as it is painful, it takes a lot of time for recovery, and that is it's a loss of work time, and which reflects on the entire family and the institution wherever the person is working. Coming to multiple small incisions, so the middle two pictures show the different sites used for laparoscopy or a multi-port Davensey surgery, or that is the robotic surgery. And on the extreme right is the further development of only one small cut in the belly button mostly, and that is it is also done in a traditional laparoscopy single incision surgery or a robot single incision surgery. So that is the difference. Next, please. So as we can see, there is a huge difference in the camera. In the first picture on left, we see the camera is held by the assistant, and it is unstable and moving. So the efficiency of the procedure comes down. It is 2D in what is routinely practiced. Only few setups have the 3D provision, where we have to have the 3D binoculars to look at the image to get the third dimension effect. On the contrary, when it comes to robotic surgeries, the camera is controlled by the surgeon himself or herself. It is very stable and the view is very clear and immersive. And there is up to 10 times magnification that gives us a huge clarity. So we can see the anatomy in much greater detail so that the precision is improved equally. Next, please. Next, we look at the instruments. So the first picture shows the instruments, which are all like straight sticks, and the jaws at the end of the instruments, they have limited range of motion. So there are only few places where the advantage of open hysterectomy is like we can use our hand the way we want it. So the same thing is not obtained in laparoscopy surgery, and that is one of the very important reasons why we needed an improvement. And this is what we are achieving in robot. So here we can see there are 4 limbs of the robot in the second picture, and they are holding the instruments with the blue heads. So these instruments have the tips which are very different. We see in the next slide. Next, please. So here is the benefit to our advantage and the outcome, the advantage to the outcome. So we can see there are 3 joints at each tip, where the range of movement is much better as compared to laparoscopic instruments. So these are the different technical details of the instrument tips, which are not necessary to go into details now. But the point is, it helps us to reach the inaccessible places where laparoscope had a disadvantage. And that loophole has been very well covered by robotic technology. Next, please. So we call it endo wrist. Endo is inside the patient's body and wrist is our wrist. So when we perform open surgeries, we actually go in and reach the deepmost places with our hands. And the same improvement and the same advantage we can have in a minimal access technology using this. So precision is what we look for, and that is what we achieve. And dexterity is ability to reach the most difficult places. So, and also the movements are mimicking our hands. As we see in the right side picture, we are holding the console, and they are called masters, where we control the movements of the instrument tips inside the body. So this movement is like a 3 centimeter movement of the surgeon's hand will lead to 1 centimeter movement of the instrument tip inside the patient's body. So that is the advantage we are having. So the tremor factor is taken care of because there are several surgeons, and as everybody is human being, they have their own sets of limitations and few problems. So this tremor does not affect the patient. That it gets filtered at the machine level itself, and intuitive motion. So there's an advanced software which enables the intuitive control instead of cross-handed. Next, please. So here we can see so many different kinds of tips suiting our purpose. So these are all adding to the advantage. Next, please. So this is called the console, where the surgeon is sitting and looking inside. And here is a very clear magnified picture where the surgeon is not disturbed by anything else, and also he can communicate with the other members in the team at the patient side. And there is a monitor inside the console. Also, there is a big monitor at the patient side where the assistants, the nurse, the entire team can be looking at, and everybody knows their job. So it is a very well coordinated and teamwork that gives us the result. Next, please. So as we see all these technical advantages, there is an obvious edge of robotic surgeries over laparoscopy. So there is a superior image quality, there is a depth perception, there is a comfort for the person who is operating. The eye fatigue is very less. The dexterity is better. There is a precision of the range is better, and also there is much ease of motion. So we do not have to struggle. And also the other advantages we have are the pain is less. The perioperative complication rate is very low. The accuracy of resection, when we need a particular part to be resected completely, that is very much satisfactory. Blood loss is very less because we can see the blood vessels as close as they are right in front of you. The conversion rates by the timing. Sometimes we start with the minimal access technology, but the disease condition or the patient condition does not permit us to do so, and we need to convert it into a open surgery, that is a laparotomy. So the conversion rates are very low with robotic surgeries. The hospital stay is short and time is as comparable to laparoscopic surgeries. Next, please. Here we are trained very well in using these machines, and what we follow is a reproducible technique so that there are no experiments on the patient. There are two arms that we are constantly using all the times. So less chances of mishaps happening. We avoid overusing energy because, again, of the precision that we have, we do not overuse the energy, which can cause potential damage inside the body. The movements are slow and deliberate, so accidents are less. We do not lose sight of the instruments. So that is how we are trained by the continuous work in this field. The advantages we have are can do a complete dissection, encounter less bleeding, this is a repetition, and it is much safe. So the structures damage doesn't happen. And with continued development, we have further improvement in the instruments and robots. So the surgeries are faster and even safer now. Next, please. So coming to the application of all this advanced technology in the simple subject of gynecology. So where we do use it very often are like cases of difficult hysterectomy, that is removal of the uterus, removal of fibroids, that is myomectomy, and endometriosis. I'm going to address these conditions in we will have an overview of these conditions in the coming slides. Prolapse repairs for stress incontinence where there is loss of control of urine, and definitely in cancers. I'm not going to address cancers today because that is not today's topic. Although robots have a very big role in cancers particularly, more than in benign gynecology. Next, please. Next slide. Yeah. So when you visit a doctor, this is for all women and for all the youngsters who have parents at home, mothers and grandmothers whom you are concerned about and you want to take care of. So definitely you need to pay attention to these things. Is there any particular health issue that I should be worried about that can affect a woman at a particular age or a particular person is at increased risk for? That is one of the questions. And what is that can be done to ensure a good gynecological health later? What are some of the subtle signs to understand that something is wrong? What kind of there is a kind of discharge or pain or bleeding that everybody experiences, but there is always a doubt about what it is. Like, there's something to be worried about, or it should be accepted as normal. And once you understand the disease condition or the health condition, what are the treatment options for the condition with all the pros and cons? So this is called an informed choice, that you understand everything about the disease or the condition you are facing and accordingly take the best possible treatment. So you have the choice to, and you have the right to make the choice and go in. Next, please. Here, of course, I would tell that the doctors are not just to provide information, but to guide you through the entire journey. So the common gynecological conditions which all of us face and we treat, like abnormal uterine bleeding, these are benign, that is non-cancerous issues, fibroids, endometriosis, and the cancers commonly are just 3 cancers related to the reproductive system in women. Next, please. So coming to an overview of the anatomy, this is how I'm sure everybody remembers a little bit from the school level, but to have a brush up, uterus is the womb, and it has an inner layer called endometrium, which grows and sheds every month in the form of periods. And this is covered by a myometrium, that is a muscle layer, which is the main part which grows and sustains the baby through the pregnancy. Fallopian tube is the tube which carries the egg and the sperm and where fertilization happens. Ovaries are the egg-producing organs. Cervix is the lower part of uterus, and vagina is, of course, the birth canal. Next, please. So what kind of menstruation is normal and what is not? A little bit of pain during the periods, an average bleed of 4 to 6 days, and no pain during a sexual intercourse or not having a back pain or cramps is abnormal. A little bit of back pain is expected during the periods, but anything more than this is definitely abnormal and has to be addressed. Chronic headaches. So mild headaches are reported in many people for 1 or 2 days, and it is acceptable. And also not being able to conceive after 1 year of continuous trial is also a reason, is also a condition that needs attention. Next, please. Why the abnormal bleeding? That is a very common question every gynecologist faces. So, and the answer is also known to many people because thanks to Google. So, but I would add here, Google is not wrong, Google is not bad. It is very good for general information, but do not try to draw the conclusions and plan the treatment based on Google, because Google is not customized. For customization, we are trained and we are capable. That is why doctors are still needed. It is not to show the importance, but understand that things do not go wrong with anybody's health. Information is very good, but decision making should not be based on information which is perhaps not even relevant for you, for a particular person. So why is this abnormal bleeding? Hormonal imbalance. So the correction we will see is also hormones. There could be abnormal growths in different parts of the uterus. There could be because of other medicines that the person is taking. So how do you know that it is abnormal? Whenever there is a bleeding or spotting in between, the periods are like they happen in less than 24 days or later than 35 days, and the time between the cycles change every month, or the bleeding is too heavy, or it lasts for more than 7 days. All these are abnormal. Next, please. Coming to treatment options, as the hormones are the reason, the therapy is also hormones in different forms. Coming to when the hormones are not curing the problem, we look at the surgical options, where we may just burn the endometrium completely, either by high temperature or low temperature. That's called ablation. And the other treatment options are removals again of the fibroid of the uterus and the condition called endometriosis, which is resected. We'll go into the details soon. Next, please. So the conditions I have marked in red are the places where robot has a very big role. This condition, these are the different types of growths in the uterus we see. So these are the common names. Next, please. So coming to the next common condition called uterine fibroids. Fibroids, as per the name, they are just benign tumors. Benign means non-cancerous. Most of them do not become a cancer ever. So tumors that grow in the wall of the uterus, that is the muscle layer. They can be as small as few millimeters, that is sub-centimeter, to as big as occupying the entire abdomen. It's like close to 25 centimeters too. So they are classified based on the location. So which is facing inside the space of the uterus where the baby is supposed to grow. As we can see here, that is distorting the shape inside the uterus, and that is definitely an obstacle to pregnancy. They are described as submucous fibroids, and they are the reasons for excessive bleeding and infertility most of the times. There are others intramural, that is, intra is inside the muscle layer itself. So those are the fibroids that cause more pain and bleeding both. And subserosal are usually less troublesome, although they can go to very big sizes too. Subserosal are growing towards the outside of the uterus. Next, please. But they are not exclusive. They are always interchanging. One can become the other one in due course of time. So how do you know that it is a fibroid? Perhaps sometimes there are absolutely no symptoms, and that is the most common. And the other times there could be heavy bleeding or painful periods. There is fullness or enlargement of abdomen because of pressure on the bladder, because of the mass itself. There could be frequent urination. There could be pain during sex, otherwise having a low back pain, complications during pregnancy, and also problems like infertility. Next, please. So how do we treat them? It is always customized. So it depends on the age of the person and the need to have children. So those who do not wish to have children, we can give them medicines. Those who want, we have to remove the fibroid. And those who do not wish to have children in the future at all, so we can either go for fibroid embolization, that is, we block the source of supply and nutrition to the fibroid, the tumor. This does not work all the time. So we have to have a proper case selection. And hysterectomy is the removal. Next, please. These are the conditions where robot has a good advantage. Endometriosis, what it is, I do not know if everybody has heard of it, but it is something like the inside layer of the uterus, those cells growing outside the uterus. So this is where, as we understand, the inside layer is supposed to grow and shed in the last 5 days. So when it starts growing elsewhere, there is no mechanism of shedding because it has no outlet. So obviously it is going to grow there itself and cause trouble. So severe grade 4 endometriosis is what we see on the right side, where the tissue which is the normal tissue which is supposed to be inside the uterus has abnormally gone outside, and it has started burying into the bladder or into the rectum or into the structure surrounding the uterus. Next, please. So what symptoms you have with this problem are like excessive pain. It is during periods, otherwise definitely after sex, and infertility, ovarian cysts, and possible pain and difficulty with the bladder for endometriosis, because unfortunately this is not very clearly picked up on ultrasound scans also. Next, please. Next, please. Yeah. What are the risk factors? The risk factors are the previous slide once. The previous slide, please. The risk factors are like not having given birth for a very long period, like very late pregnancies. That's a possible risk factor. And where the menstrual periods last very long or very frequently, or a family member having the same condition, or some health issue which makes the outflow of the menstrual blood difficult, and also damage to the cells because of an infection. Next, please. Next. Yeah, how do we treat? There are several options here, depending on the age and the purpose. There are different treatments, the details of which are out of purview now. But these are one of the most difficult surgeries in gynecology, and which can lead to several complications. So here, the robot has a very, very good advantage because we can see the tissues achieve the result the way we desire it. So is there a way to prevent this problem? There is no definite way. However, estrogen, that is the female hormone, is the reason for this. And to keep the estrogen levels low, you have to have a normal weight, exercise regularly, keep a low amount of body fat, and avoid large amounts of alcohol and drinks with caffeine. Next, please. Pelvis. Pelvis is the lowermost region of the abdomen and which contains the pelvic organs. So pelvic organs include the bladder in the front, the uterus in the middle, and the passage for motion, that is the rectum at the back. And along with that, there are bowel loops coming in between the spaces. Next, please. So why are we discussing about pelvis? Because there is a condition called pelvic organ prolapse. So as we discussed, the three main organs, bladder, uterus, and the bowel, the rectum. So prolapse is nothing but dropping down. So this is a condition where the pelvic organs are leaving the normal position and falling down. So this occurs because supports are loose. The pelvic muscles, which form a network under the pelvic organs to support these, they become loose, or the connective tissues otherwise which are holding the organs, they are either loosened because of injury or because of health condition. So prolapse, it can lead to additional problems like difficulty in holding urine and also difficulty in moving motions, that is described as fecal incontinence. Next, please. So the types we can see in the front, in the second picture on the top, we see the front structure, that is the bladder falling down, next the uterus falling down, or the back, the rectum coming down. So the picture which we see is at the lower part of the slide, we see that there is a prolapse visible at the vaginal entrance. So this is the uterus coming down, and it can come further down as well if not at any time. Next, please. So why does this happen? As we just described, the muscle weakness or relaxation because of injury, or the body tissue type itself leads to the descent and sagging out of the uterus. So there are different degrees described depending on the extent of the problem. Next, please. Similarly, when the uterus is not there, the cuff, the blind pouch of vagina, it drops out. And that is described as vaginal vault prolapse. Next, please. What are the risk factors? Like multiple pregnancies and multiple childbirths, vaginal delivery particularly. It has a risk higher than cesarean section. That does not mean that cesarean section has no risk. In addition, advanced age, menopause, conditions leading to increased pressure like chronic asthma, smoking, obesity, or a radical surgery which has been done in the pelvis previously, or connective tissue abnormalities, which is a different set of problems completely, and it could be genetic too. Next, please. So what is the usual symptom that these people face that is typically described as a bulge or a dragging? And that this complaint, the bulge or the dragging sensation that comes down is exacerbated by standing, walking, and it is alleviated, that is reduced if the person lies down. There is a sensation of heaviness and a feeling as if sitting on a ball or a mass protruding, painful intercourse or frequent urination or loss of urine or repeated bladder infections because the person is not able to empty the bladder properly. There is a backache and a difficulty walking. So do make sure that here I would like to reiterate that most of the problems are secretive. People do not want to discuss about these problems, although we have so much of technology available to solve all these problems and give a better quality of life. I'm not saying that somebody is going to die because of this problem, but are they really living a good life is the question. And that is what I would really like to focus on, that please ask the elders at home if they have any of these problems, they need help. And you would give them a much better quality of life than giving them gold or similar. So this is these are the problems which have to be paid attention to for living in a better way. Next, please. I'm insisting on this particular topic because this is what we are practicing in our department, and we wish that the message and the facilities and the services that we have reach the majority and people are helped. So coming to anterior, these are the technical details about the anatomy, like the bladder coming down called as cystocele. The next, please. The apical compartment is nothing but after the removal of uterus, the blind pouch of the vagina that remains. It has bowel loops above it. So when the bowel loops are dropping down, it is described as enterocele. Next, please. Coming to therapies, so there are some silicone devices which are just put inside and they hold the uterus in its place. So they are okay for temporary measures, and very, very old people who are not capable of undergoing the surgery for other medical reasons. For them, these are good options, but they are not permanent solutions. So coming to the next, please. Exercise. Are not working, we proceed with surgery. And we come into the picture. So where is that pelvic reconstructive surgery is what we call them. They restore the natural position of these organs and to maintain a satisfactory sexual function as much as we can deliver. So the types of surgery include using the native tissues. That is what the body is actually having itself. So that these are the details of surgeries are written there only for doctors to follow. And there are ligament suspensions and there are grafts that we use to have a better repair with better result. And there is another one that's sacrocolpopexy, which we'll be addressing soon. Next, please. Yeah, the natural orifice surgery is claimed to be better than even minimal access laparoscopy or robotic surgery because we are not even making one keyhole. It is just through the natural orifice that the surgery is being performed. So here we use the native tissues itself. But as we have known and as the studies have shown for decades, there is some problem with the native tissues. That is why the prolapse initially happened. So there is a good number of such surgeries which fail and the patients come back with repetition of the same problems. So here is the role and the need for further improvisation of technology and devices. So the ligaments which are existing in the body. Ligaments are nothing but tough structures which hold the things in place. So these are the names, sacrospinous and uterosacrals, which are our pillars of success. Next, please. See, this is also a further improvement where we put a graph, please. sacrocolpopexy is, as the big name shows, everybody knows there is a lower part of the backbone that is called as the sacrum. And it is a bony form structure to which we anchor the pelvic organs that are dropping down using a mesh. And that is simply described as this procedure, sacrocolpopexy. As with all the studies over several decades, that is described as the gold standard. And to perform this procedure, it takes a lot of expertise and practice. And it can be done either by an open surgery, by laparoscopy, or robot. And here again, robot has a tremendous advantage over the other techniques. So here we are resupporting the vagina using a mesh. Next, please. Another important aspect of gynecology and urogynecology is incontinence, where the person is not able to hold the urine. And whenever there is an increase in the pressure, like a cough or a laugh or even a change in the position, it can lead to leakage of urine. That is described as stress urinary incontinence. And here, there has been a lot of changes in the forms of treatment of this condition. And the procedure in demand now is birch procedure. So here we put some stitches in a very inaccessible part of the body, suspending the corpus to particular ligaments called Cooper's ligaments. So as we can see in the small stitch, the stitches where we want to put the stitches, it is very difficult to reach there. So to overcome this trouble, we have the laparoscope, we have the robot to our advantage, and this procedure becomes very simple, and we can deliver a very good success to the person, to the patient we are treating. Next, please. So towards the end of this exhaustive details, I would like to say that what do we learn from whatever today's session? So we have to be the advocate of our own health. Everybody has to take his own responsibility. Take steps to be healthy. Talk to your doctor, whatever doubts or concerns you might feel, or doubts you may get because of the knowledge you get through Google. Know your treatment options in details. You should know all the pros and cons of each treatment detail and know which treatment suits you best. And of course, here the doctor is going to guide you and make an informed choice. So make your life better and live it to the fullest. That is what